यो विश्वं विदधाति पाति सततं संहारयत्यञ्जसा सृष्ट्वा दिव्यमहौषधीश्च विविधान् दूरीकरोत्यामयान् विभ्राणो जलनाचकास्ति भुवने पीयूषपूर्णं घटं तं धन्वन्तरिरूपमीशममलं वन्दामहे श्रेयसे वन्दामहे श्रेयसे वन्दामहे श्रेयसे। ॐ शान्ति शान्ति शान्ति।
Welcome back, my friends and colleagues, to our Prerequisite video series. This is video number 5, and in our series we have one more after this, and we've placed this video strategically in the series so that we can get an overview of diagnostic testing, medical terminology, and medical coding before we look at the clinical examination on video 6 with Dr. Segal. So today's video will cover diagnostic testing, both the imaging as well as chemical testing, medical terminology, and coding. Medical imaging is a very large area in Western medicine, and some people will say that the stethoscope has gone by the wayside and doctors only make diagnoses by doing medical imaging, and in some areas that's very true. Medical imaging was birthed in the late 19th century with the discovery of the X-ray by William Conrad Röntgen. And Dr. Röntgen, who was a physicist in Germany at the time, made a unique discovery when he was working on the physics of working with a cathode ray tube. As the cathode ray tube was turned on, he noticed across the room some luminescence on a bismuth plate, and he didn't know what was causing it, but he felt that there was a cause and effect between the cathode ray tube and the bismuth plate luminescence. And since he couldn't figure out initially what this was, he used, the letter X to denote these rays that were being emitted by the cathode tube and luminescing the bismuth plate. So he coined the term X-ray. This was discovered in November of late 19th century, and then over the next 2 months, Dr. Röntgen categorized and classified these rays and measured them, understood their properties, and published a series of articles in the German literature, then the English-speaking literature shortly thereafter, and won the first Nobel Prize for Physics a number of years later for the discovery of the X-ray. It's interesting that Dr. Röntgen was offered a position as a physicist and a clinician at Columbia University in New York in 1914, and as he was about to leave Germany, World War I broke out, and he was not allowed to leave Germany at that time, and subsequently never made it to the United States. A number of his relatives did come to New York and the Midwest, but Dr. Röntgen never made it here. The X-ray, and this slide shows how an X-ray is produced. The physics behind the X-ray is a filament is heated up, looks like the inside of a light bulb, and an electron beam is generated by the heated filament, which is shot towards a rotating anode, which is the opposite side of the tube, generally made of tungsten, but some X-rays use molybdenum nowadays. And As those electrons are accelerated and hit this target, they generate these waves that then pass out through a focused window and are directed towards whatever you want them directed towards. In diagnostic imaging, we use these to look inside the human body, and in the past we would use a photographic plate to develop behind or in front or beside the patient, and nowadays digital imaging uses receptors that collect these beams, and the beams, whether they be full beams or attenuated beams, depending on the type of tissue they penetrate. This is a frontal radiograph of the chest of a young woman, and you can see there are different shades of gray here. There are areas that are white and areas that are nearly black. Areas that are white absorb the most X-rays, so the film does not get as exposed, and areas that are black absorb the least amount of X-rays, so it's increased penetration of the X-ray, so the film is more exposed and it looks black on the film. You can see the background on this X-ray photograph is completely black because there's no tissue for the X-ray beam to be attenuated. And on this frontal X-ray you can see that the gray areas, on either side of the thorax are the lungs, the teardrop structure in the middle is soft tissue, is the heart, and the very white structures are the bones. The important thing to remember about X-ray imaging is that while it's a very powerful tube, it involves ionizing radiation. We're heating up those X-rays, heating up those electrons that are shot against the target, and then produce the X-ray beam. And the way it interacts with tissue, in order to produce the image, is it ionizes the tissue. And the problem with ionization of the tissue, it can, in excessive amounts, be the source of tissue damage. And potentially the development of cancer. So judicious use of X-ray is important. X-ray is also used for therapeutic purposes, in terms of using high-energy X-rays for killing tissue, particularly in cancer care. So X-ray is a powerful tool used to image patients. Primarily nowadays used still to look at the lungs, as in the chest X-ray here, which is the single most common X-ray performed in the United States, and also looking at the bones, particularly for fractures and injuries. In terms of the chronology of diagnostic imaging, the next most important area to develop was ultrasound. And the ultrasound principles are that sound waves can penetrate tissues and be reflected back from tissues and produce an image. So what you see here in the image is that a sound wave generator, an ultrasound wave generator with frequencies between 2 and 20 megahertz, produces these waves that come out of the structure and then impede on that pink ball and would bring sound waves back to the receiving element and produces an image. You don't need to know the details of the principles of how ultrasound works, but know that production of a sound wave at approximately 2 to 20 megahertz is shot out of this transducer, and the transducer acts as a receiver coming back, measuring the reflected echoes, the sound waves coming back from an object. And on the next image you can see typical ultrasound examination, and this is a side view of an intrautero image of a baby. The head is to the right, the feet are to the left, the thorax is in the midline. And anything that reflects tissue back is going to have bright echoes. So bone, soft tissues would have bright echoes. And anything that has no tissue interface, such as the fluid, the amniotic fluid around the baby, will be black, will be a signal void. You can see some black areas within the baby. Those are the vascular structures, the portal vein, the posterior margin of the heart, and the aorta, which have flowing blood and which show no echoes on ultrasound. So ultrasound is a valuable tool. The ultrasound waves do not produce ionization and are therefore safe to use at any age and don't have any biological harm. There are some reports that say that ultrasound excessive use can warm up tissues. And so therapeutic ultrasound, particularly in athletes, is sometimes used to heal tissues by warmth. Moving forward in time, CT was developed as an offshoot of X-ray, And CT, if you look at the image on your screen now, the front top part of the image shows an X-ray tube that sends out a fan beam of X-rays that's received on a series of detectors in a circle. And this rotates around the patient who's situated in the middle of the tube on a table and measures the tissue differences at a number of different locations as this X-ray tube moves according to that arrow, in this case to the right side of the patient and circumferentially around the entire patient. The initial X-ray machines were produced in England by a company known as EMI, and an interesting, fact was the discoverer of the X-ray, Godfrey Hounsfield, was in the science division of EMI in the late 50s, and EMI was a small British company and was running out of funding for their science division. And they also had a music division, and the music division had recently signed on a group known as the Beatles. And in 1963, when the Beatles became widely popular, the money came back into the EMI, was able to fund the development of the CAT scanner, which Hounsfield then was able to complete his research and patent the CAT scan, and subsequently went on to win the Nobel Prize in the 80s for the discovery of the CAT scan. The CAT scan, excuse me, like X-ray imaging, does produce ionizing radiation, and as a result, it should be limited in its use. However, it can give elegant image like you see on the next screen, a side view of the human body and a front view of the human body, which demonstrates the anatomy of the thorax and the abdomen very well. The upper half of the body separated by the diaphragm, the heart in the center. You can see in the left upper lung zone, which would be to your right, there is a lung cancer. And below the diaphragm, you can see the liver on the left side, the spleen in the right upper quadrant, the stomach, aorta, and adrenal glands, kidneys, and intestines. So it gives us an excellent anatomic and pathologic detail, but limitations should be considered in the use of it as a result of ionizing radiation. The next diagnostic tool, chronologically speaking, is the development of magnetic resonance imaging. And magnetic resonance imaging is completely different than X-ray technology. Uses radio frequency to image patients who have been placed inside a high field magnet. And as a result of radio frequency movement of the atoms, the hydrogen atoms in particular in the body, images can be generated. As a result of non-ionizing radiation in these patients, MRI is considered a safe study. The only contraindications on MRI, patients who have any magnetic implantable devices such as pacemakers, old-fashioned aneurysm clips, and cochlear implants, which may be damaged or moved as a result of being inside a large magnetic field. The next image you see is a side view of the human brain, and what magnetic resonance offers us that CAT scanning does not offer us is exquisite tissue differentiation. The virtue of magnetic resonance imaging is it takes its imaging based on the amount and volume of water or hydrogen ions in tissues. So if there's slight differences in water concentration in tissues, you'll see a difference in the grayness on the image of your screen. So that's why if you look at the side view of the brain, you can see the peripheral margins of the brain are darker than the central margins of the brain. That's the differentiation between the gray matter on the outside and the white matter on the inside. So it's very good for tissue differentiation, taking imaging based on water molecules and hydrogen ion concentrations. The final area that you may read about and hear about in terms of patients' histories, and when you look at some patients' charts or referrals, is nuclear medicine. And nuclear medicine is probably about the same age as ultrasound, and what it is kind of a reverse sort of X-ray. And radioactive pharmaceutical is placed inside a patient, oftentimes through the vascular system, and then collects in an organ that you want to image. Brain, the liver, particularly the heart, and other organs. And in the image you see on your screen, patient is injected with a radiopharmaceutical that's accumulating in the brain, and these radiopharmaceuticals generally emit gamma rays, which are low-level radiation, relatively safe, and then collected similar to a CAT scan type of format in the circumferential array, which produces the subsequent images you see to the right of the patient's head, which is inside the scanner. Radiopharmaceuticals on the next image you see oftentimes used to detect bones. You see the images of the skeletons on the next image. This is a phosphate radiopharmaceutical that's picked up by actively forming and actively metabolizing bone. One of the downsides of nuclear medicine imaging is that the earlier nuclear medicine imaging were two-dimensional images. And as you can see on this bone scan examination, limited in terms of spatial resolution and spatial detail. Since then, imaging has taken a step forward and has combined the nuclear medicine imaging with three-dimensional imaging of CAT scanning and fused imaging. And you can see in this series of images, which is imaging the heart for disease. The first image is a CAT scan, the second image is your two-dimensional nuclear medicine image. The third image on the right is a fusion image which demonstrates the bright area of the apex of the heart. The yellow spot is an area of tissue damage in the heart, which now can be imaged in a three-dimensional fashion. Unfortunately, this fusion type of imaging generates a significant radiation dose to the patient and should be used very sparingly. But know that it exists, and know if you read a chart that talks about fusion imaging or PET, P-E-T imaging, positron emission tomography imaging, this is what they're talking about, and this is what they're looking at. And we will discuss each of these areas of imaging in more detail as we go through the systems approach, when they're useful, what they're useful for, how to speak to patients about them. Not going to have you guys have any real understanding of what to order, or how to interpret to make diagnosis, but just have a working knowledge of the utility of these imaging mechanisms, as well as the downsides of imaging. Now we leave our discussion of medical imaging and look at laboratory testing. And laboratory testing is very useful and important to have a basic working knowledge of tests that your patients will come to you hand in hand sometimes. So you know what they're talking about, what clinicians are talking about, and able to have an intellectual discussion with colleagues, medical doctors, nurses, chiropractors, naturopaths, oriental medical doctors, who may be using some of these tests for making medical diagnoses. The laboratory tests we generally do involve bodily fluids, and with a few exceptions. And the most common laboratory tests we do involve the blood, and many laboratory tests involving the blood, urine, stool, sputum, and cerebral spinal fluid. And when we look at the blood, we look at a number of things in the blood. The most common things we look at in the blood are first the electrolytes that are circulating. And of these, the four most common electrolytes circulating are sodium, potassium, chloride, and bicarbonate. You know, the big four, the top four. And those operate within a relatively narrow range of health. And it's important to know and understand what those normal ranges are, because they, in balance, can produce certain clear physiological signs and pathological symptoms. The next commonly ordered test is the complete blood count. And the complete blood count is looking at the formed elements in the blood primarily, looking at the red cells and the white cells. And of the red cells, the two most commonly ordered tests are the absolute volume of hemoglobin in the cell and the hematocrit, which is a percentage of number of red cells per unit of plasma, usually per cc of plasma. In addition to that, white blood cells are analyzed into their absolute numbers, as well as the presence of platelets for knowledge of their patient's ability to clot. Functional tests are commonly ordered, and the most common functional tests are usually those related to endocrine abnormalities, which we will be discussing in some detail in our fifth lecture series on endocrine studies. Looking at hormonal abnormalities, commonly measuring thyroid function using T3, T4, and TSH, and in diabetes looking at fructosamine, insulin levels, and hemoglobin A1C, which are tests you'll hear a lot about and should have a basic knowledge of where they fall in the normal range and abnormal ranges. Not that you're making the diagnosis, but that you know where your patient is coming from. Tests most commonly ordered nowadays by cardiologists and primary care doctors are looking at lipid profiles in the blood, primarily looking at cholesterol, because there is concern that cholesterol levels may be related to increased risk of heart disease and heart attack. Other lipids in the blood that are looked at are triglycerides and lipoproteins. And the two most commonly examined lipoproteins are the low-density lipoproteins, which is known as the bad fat in the blood, and high-density lipoproteins, which are considered the good fats in the blood, the scavenger fats in the blood. And then finally, markers of inflammation, which are very important to us because the etiological basis of most disease in Western culture is inflammation, starting from heart attack through cancer and all of our itises. And the commonly used laboratory measures of inflammation are blood tests that measure the ESR, or the erythrocyte sedimentation rate, which is kind of a wastebasket examination, the CRP, which is the C-reactive protein measurement, and homocysteine levels. And we'll talk about these a little more in depth when we get to several of the systems, particularly the cardiovascular system. And those are kind of an overview of some of the laboratory tests you'll see, and as we walk through each of our organ systems, we will touch on the appropriate laboratory tests that you should have a basic knowledge of and what the data means once you see it. Now we're going to move to a brief overview of medical terminology, which is kind of a fun thing. Medical terminology teaches you how to speak doctor, you know, and most medical terms are Latin or Greek root derivations. The importance of learning about medical terminology is you can have, you know, intellectual conversation with your colleagues, you know, and talk doctor to each other. But more importantly than that, it's very useful for data collection. So by making and using the right terms, codes are assigned to the terms that can collect data and look at epidemiological patterns of disease. So data collection is important in terms of determining epidemiology. In addition, medical terminology is the single most important factor in determining reimbursement by using specific coding sequences that tie procedures to diagnoses that yield payment. And right now, while Ayurveda is not being reimbursed by medical insurance companies, at some time in the future it may come that we will need to know these types of terminologies so we can have appropriate reimbursement for what we do. And in addition, when you receive information from colleagues, there'll be numerous abbreviations that are commonly used in medical charts. It's important to have kind of an overview and understanding of certain key abbreviations that are seen on most medical charts. On the next slide, we're going to look at making medical words. And medical words, medical terms, are generally a combination of some root word, you know, that describes something. It may be a function, it may be a structure, and something added to it at the beginning, a prefix, or a suffix added to it at the end. So for example, we have here, pnea, P-N-E-A, is the root word which means breath, also can mean lung, and tachy is a prefix that means rapid. So if someone is breathing rapidly, and there's a typographical error on that last thing there, so rapid breath, tachypnea is rapid breathing. So prefix group plus suffix is the medical terminology. So tachypnea, rapid breath. And this is a slide that will be included, in my PowerPoint that you'll be able to see a little better than on the slides. This tiny little words here are the 40 plus most common root words used in medicine. The first row, cepho, oto, opto, glosso, rhine, naso, oro, are words that refer to the head and neck region. So cephal is head, and you can envision a word that can mean headache would be cephalgia. Algia is pain, cephal is head. So head pain would be headache. The next row, cardia, aorto, pulmono, tracheo, broncho, thoraco, are words that refer to the cardiovascular system and major vascular structures. Cardio is heart, aorto is aorta, obviously pulmono is lungs. The next two are a series of words that refer to the gastrointestinal system. So it's gast, pharin, esopho, colo. Okay, gastra. Gastritis would be inflammation of the stomach, gastra. Pharyngitis, inflammation of the pharynx or throat. Esophagitis would be inflammation of the esophagus, and colitis would be inflammation of the colon. So using the suffix itis, inflammation, you can make any inflammation in the upper intestinal, lower intestinal system. Hepat, bili, coli, neph are the liver and gallbladder. Neph refers to kidney. The next two groups, arthrosynovio, osteocardial, spino, vertebro is the musculoskeletal system. Myo-rhabdo included in that, meaning muscle. Masto-mammo is referring to breast. Gyne-utero, ovotestopini, scrotocysto is the genitourinary system. Veni, art, cap, ang, lympho is the vascular system peripheral. And thyroadeno are two of the endocrine terms that are commonly used. Thyroiditis, inflammation of thyroid, hypoadrenalitis, lower functioning, and inflammation of the adrenal glands. So we'll deal with each of these as we go to each one of these sections, getting a basic working knowledge of the root words and some of the common prefixes and suffixes will give you a real handle on and how to read and interpret medical charts and information you may receive from clinicians, and how to speak with clinicians. Commonly used symbols, obviously left and right with circles around them, arrow up, arrow down, increase or decrease. The Greek letter, capital letter delta, is often used to represent word change. Implies or moves into, arrow sideways, unknown or equivocal, two arrowheads, none is a circle with a slash through it, male or female, circle and square. After or post is a P with a line on top of it, indicating something is after or status post has been completed. Doctors and nurses are lovers of abbreviations, and these are just a handful of abbreviations that you'll see in charts, and we'll go through a more extensive list of abbreviations as we move through the systems. BP is blood pressure, CAD is coronary artery disease, COPD, chronic obstructive pulmonary disease, DX diagnosis, RX treatment, BX biopsy, FX fracture. The last three are abbreviations that are used for coding purposes. CPT, common procedural terminology, is the coding we'll talk about at the end of this lecture. And DRG, diagnostic related groups, is what groups of pathology your patients fall into. One that's not on here is ICD, International Classification of Diseases, which is linked to the CPT, in order to create the DRG, which causes us to get our money. So here's a typical thing you might see on a chart, the patient who came to you, for an Ayurveda consultation, 84 YOLOLF and NAD with PMH of COPD, CHF, DNA, FIB, MRSA, and PSH, CABG times 4, RTKR, LTHR, CC, CP will need WU for R/OMI. So what does this mean? So this means an 84-year-old, LOL, little old lady, female, in no apparent distress with a past medical history of chronic obstructive pulmonary disease, congestive heart failure, diabetes mellitus, atrial fibrillation, and methicillin-resistant Staph aureus, and a past surgical history of coronary artery bypass graft times 4, right total knee replacement, left total hip replacement, with a chief complaint of chest pain. She will need a workup to exclude or rule out myocardial infarction. So if this patient came to you, she has had heart trouble. She's been in the hospital with a Staph aureus infection that was methicillin resistant, that she's had joint replacements, and now she has chest pain, and she's being worked up for a possible myocardial infarction, which would require a whole series of tests, which we'll talk about when we get to a cardiovascular section. This slide says, wow, I could have had a 99214. So what is a 99214? We now get into the realm of billing and coding. And medical coding and billing is an important area for the reasons I already stated in terms of data collection and medical reimbursement. And here's a list of typical codes. 99381 is initial examination with a new patient who's an infant. So it's a descriptor of that code. Each of our codes, based on Medicare, CMS, the Center for Medicare Services, has a description of it. So you can go to the website, cms.org, and see each one of the CPT codes listed there with a descriptor and a way to code your patients. The CPT codes, after you've diagnosed the patients, result in your diagnosis-related group codes. So the first box here, your diagnosis code, which we're now on the 10th iteration of diagnoses codes, which is the reason for seeking care. The example here is diagnosis code is E11.9, which is adult onset of diabetes without complications. And the procedure you're going to be doing on that patient is a blood glucose measuring, a monitoring device, which is 82962. So the procedure is linked to the adult onset of diabetes because the patient has a glucose abnormality and you're using a tool to measure their glucose. So that would be approved for care by CMS or by whatever insurance company you are submitting your code to, and you would get reimbursed for it. If you coded the diagnosis of E11.9, adult onset diabetes without complications, and then you had a procedural code that was unrelated to it, such as Xray of the ankle, that would not be codes that were able to be linked because they were discordant, and it would be rejected by the insurance carriers as being payable, and CMS as well. Plus, it wouldn't produce valuable information to collect data on. Not that a diabetic wouldn't need an X-ray, but the code for diagnosis for that X-ray would have had to have been something like ankle injury or ankle pain, and not diabetes. Second example is V25.1, which is a flu vaccination diagnosis, and the code or procedure that was done was 90660, which is intranasal flu vaccine. So that are linked, those are related, and those will be collected for data and paid. So the diagnosis code, the CPT code, the ICD CPT yields a category, diagnostic-related category, that allows us to be reimbursed and allows us to collect data. Know that you'll see these codes on patients' charts. The same location, the cms.org, also lists the ICD-10 codes, and you can just plug in a code or plug in a diagnosis and get a code either way to try and figure out what you may be looking at, what you may be working with. So in conclusion, I know that you have a feeling for, some of the things we're looking at in terms of diagnostic testing, laboratory testing, an overview of medical terminology, and a brief understanding of abbreviations and coding, all of which we will deal with significantly more depth in future lectures. And I leave you with this diagnosis, and for your own homework, I'd like you to go and try and figure out what this is. This patient has dibertriglycerohemofibromyalgiosis. So, dibertriglycerohemofibromyalgiosis. And figure out what that is, and you can email me through Hillary's website with the diagnosis. And thank you, and enjoy the next lecture by Anusha on the clinical examination.